Welcome, everyone. Thank you so much for joining us this afternoon. For those of you who don't know me, my name's Rachel. I'm part of the care team here at PPMD, and I am joined by a stellar cast today to educate us about fat embolism syndrome, avoiding falls, recognizing those signs and symptoms, especially as we head into the cold weather season for a large part of the country where falls can be a little bit trickier to navigate and to avoid. As a reminder, this is being recorded, so you'll be able to view this back after the conclusion, and we're happy to take your questions as well. So if you have questions throughout the presentation, don't hesitate to drop a note in the chat function below, and we look forward to answering as many of those questions as possible. This is a common topic that comes to PPMD and my teammates very frequently throughout the year, talking about how to avoid falls, how to be safe in power chairs or when, walking across uneven surfaces, and then what to do when a fall happens and when potential symptoms arise, how to manage those symptoms. So we've got a great crew today with us covering neurology, physical therapy, cardiology, and pulmonary, and they're each going to tell us a little bit of this story about how to avoid falls and recognize those signs of FES. So without further ado, I'm going to hand things off to our first presenter, Dr. Sarah Wright, who's the director of the Neuromuscular Clinic at Children's National Hospital in Washington, D.C. Dr. Wright, go right ahead.
Great. Thank you so much, Rachel. And thank you to the community for inviting us all to speak today. Next slide. So we're going to talk a little bit first about what is fat embolism syndrome. This is a very rare disease in and of itself, and obviously more common in the Duchenne community. And so that's why we're focused on this today. I thought this was a really nice infographic to kind of walk us through what happens. And so most commonly, fat embolism syndrome starts after a particular injury to the bone. Most of that is a fracture or an injury, but it can be just a small kind of a bump where it's not a large fracture sustained. Very rarely from spinal instrumentation or bone instrumentation from orthopedic procedures can this predispose to fat embolism syndrome. And what happens is that the bone marrow fat then actually enters into the venous circulation. That's number 2 there. And you can see that actually those little fat particles embolize to a couple of different places. They can go to the pulmonary capillary bed, and then from inflammation in the pulmonary capillary bed, they can actually go into the systemic circulation, we call that, so into our arteries. They can also, if there's a small hole in the heart, they can pass through the heart, and then they can disseminate even up into the brain. And all of these little emboli can go into different organ systems within our body, so the liver, the kidneys, even into the eye with the retina, the small vessels of the eye, and of course throughout the bloodstream. And my colleague, Dr. Cunningham, is going to go through kind of what that may look like. And so we're going to talk a little bit first about this fat embolism syndrome and then how we can potentially prevent it. Next slide. So as we mentioned, and the reason why we're all here today is that fat embolism syndrome is unfortunately more common in Duchenne. And it seems to be that this is due to kind of a, quote, perfect storm. So there's a couple of predisposing factors in Duchenne muscular dystrophy. Number 1 is that we know that there can be bone fragility due to muscle disuse. And then, of course, chronic corticosteroids and decreased mechanical load from loss of ambulation that would put increased risk of stress on the bone or fractures. And then for some reason, we also know in Duchenne that there seems to be increased marrow fat and fatty tissue. And so there's a greater reservoir of fat to embolize if there were to be an injury to the bone. And then also as the disease progresses, individuals with Duchenne and young adults and adults can have reduced cardiopulmonary reserve, which can lead to essentially less compensation when those fat emboli come into the pulmonary system or cause microvascular compromise. Next slide. And so the bone health is in Duchenne is really multifactorial. So we know the biggest hitter is corticosteroids, which we'll talk about in the next few slides, but it's actually been shown that there's multiple different factors in Duchenne that lead to this disruption of bone health or homeostasis, including systemic inflammation. And so there are certain things that are released in our body, inflammatory states called chemokines and cytokines. And one of those, actually, IL-6, is a current target for a clinical trial for looking at bone health in Duchenne. But it's both that along with some of these inflammatory particles within the muscle, genetic factors, a dysfunction of the vasculature, loss of ambulation, and a really significant hormone imbalance that we can see from steroids in Duchenne that lead to this state where the bones can become more fragile. Next slide. And so what are these external factors that we can actually act upon? We can't change our genetics. We can't change the inflammatory milieu in our muscles or our blood system, but we can certainly look at some of these external factors and how they impact bone health. And of course, the biggest hitter is corticosteroids. So it's known that even within the first year of corticosteroids, you can see about a 6 to 12% decrease in your bone mineral density, and then an additional 3% in your decrease in your bone mineral density every year after being on steroids. And corticosteroids traditionally inhibit bone formation, increase bone reabsorption. They also impair the absorption of calcium from our gut, and calcium is very integral and very important for bone health. Also, there's significant vitamin D deficiency. So some studies have shown that up to 84% of patients with Duchenne, despite supplementation, can have low vitamin D levels. This can be due to a loss of ambulation, all of us living in northern latitudes where we don't get much sun, as well as just decreased dietary intake. And then corticosteroids directly also break down vitamin D even further. Another factor is that individuals with Duchenne have a larger fatty tissue, and so that actually enables the vitamin D to distribute into the fat, and so it's less readily available for use. And then, as we discussed, there's the loss of ambulation, which reduces mechanical pressure loading on the bone. And that decreased mechanical loading will actually further kind of accelerate bone loss or osteoporosis, which is weak bones. Next slide. So I wanted to put a little caveat into the corticosteroids. As some people may know, there's been a medication that was recently approved for Duchenne muscular dystrophy called vamorolone, and it is still a steroid, but it works in a slightly different way. And it's some of that mechanism of action where there's decreased activity of what we call glucocorticoid response elements that may lead to improved outcomes. And so in the clinical trial, there was a 24-week trial that then was extended to 48 weeks. And those participants who were on vamorolone experienced essentially no changes in their CM markers of bone turnover compared to the prednisone-treated group in the trial. And actually, when they looked at a group of patients from what we call natural history controls, so from different databases from the past, they actually also saw a decreased rate of vertebral fractures. And so those patients who are on vamorolone throughout the trial had 13% risk of vertebral bone fractures compared to 30% of those patients who were on daily deflazacort or daily prednisone after about 3 to 3.5 years of exposure. So this is a mechanism that may be a little bit more protective of bone health than traditional steroids. Next slide. And so recommendations for bone health screening, the PPMD and the Bone Health Consortium, who've been really looking into bone health, along with Dr. Leanne Ward, who's an endocrinologist in this field, have done an excellent job about trying to create guidelines for all of our care centers to make sure that we are doing very proactive work to prevent poor bone health from occurring. And so I really liked the framework with which they discussed this. And so they talked about the skeletal health monitoring phase. And so this is the proactive and the preventative care. So it's really important to make sure that once we are starting on steroids, we're getting lateral spine radiographs or spine films of the lower spine every 1 to 2 years, and even 2 to 3 years if patients are steroid naive, because unfortunately, like we talked about in Duchenne, even without corticosteroids, there can be loss of that healthy bone over time. Also, those should be obtained sooner if there's any back pain or if we see decline in the bone mineral density scores. These are average scores. Additionally, we should be looking at a bone health scan, which is the short term for it is a DEXA. And so that should be done at least with starting with steroids and then annually thereafter to really look at the bone health or the bone mineral density, how it's changing over time, so we can be proactive about treating that when it starts to decline. Calcium intake should be screened annually, and oral supplementation should be provided if we're not getting enough calcium in through our regular diet, through things like cheese, yogurts, ice cream. And then obtaining a vitamin D level annually and supplementing if that level is less than 30 based on what your endocrinologist advises. And also, as Megan's going to talk about after me, the importance of fall prevention that should be discussed at every single visit with your clinician. Next slide. And so when do we actually treat? So this is kind of the treatment phase. And so many of you may have heard of that there's a medication called bisphosphonates. It's available in different forms, intravenous or oral. Intravenous has been the most studied in Duchenne muscular dystrophy. And that is really a treatment that can help with bone mineral density once it starts to decline. And so this should be really started when there's clinically significant bone fragility. So that's defined as a patient having at least one lower back vertebral fracture or a back vertebral fracture or one lung bone fracture. That's a definitive diagnosis of a clinically significant bone fragility, or if there's a really high risk for fracture. And most centers are now adopting this modality to be proactive, that if we see signs of systemic steroid exposure, so delays in the bone age, if there's higher degrees or doses of glucocorticoid exposure or increasing weight, decline in those DEXA scores that we see, the bone mineral density scores on DEXA, or a critical loss of function, we should be thinking proactively about trying these treatments. Next slide. And so this is a very busy infographic, but it talks a little bit about what we were talking before about what's the importance of monitoring in the initial stages, and then when do we get to treatment. And so with that monitoring we talked about there's some baseline labs to be doing, and then monitoring spine films, as well as monitoring your overall DEXA scans while on steroids. And then when that clinically significant bone fragility occurs, or being proactive about that, that's really when we start the initiation of bisphosphonate therapy. When to stop that bisphosphonate therapy is difficult to determine. It's determined based on essentially your bone age and your overall maturity of the bone. And so that bone continuation of bisphosphonates is necessary, and going into the maintenance phase as well until it's determined that the bone has fully matured. And there are certain times where that may fluctuate. And so it really does take a good care team as well as a bone health team and endocrinologist to help guide when treatment is indicated and how long treatment should continue for. And one of the things that's interesting to note and important to note is that there are some other treatments that can also help with bone health. So in particular, we talked about hormonal imbalance leading to osteoporosis. So even the initiation of testosterone has been shown in some studies to actually improve bone health overall. Next slide. And so what do I really want to emphasize is that fat embolism syndrome, timely identification and treatment of fractures is really the key to prevention. We're going to talk about everything that you can see, and also Megan's going to talk about fall prevention, but really you should know the signs of a fracture. And all of us can think about, something that is a big fall leading to very significant pain and of course sudden loss of ambulation, but signs can be more subtle. So guarding or decreasing movement of one particular limb. If you're experiencing unexplained back pain, that's particularly in midline, and it's not going away, or if you have localized pain, swelling, and deformity of a particular area of the limb, that's something to keep in mind. And then it's important when you see those signs to detect the fracture. So seeking out care urgently with your primary care doctor or an urgent care or your orthopedic doctor if you have one, to obtain plain x-rays or radiographs of the affected area. And if there's no fracture on that radiograph and your clinical team still has a very high suspicion for fracture, that's when an MRI of the actual area can be implicated. And then the important thing also is to kind of stabilize and to treat. So for early orthopedic consultation, it's important to kind of avoid traction of the actual extremity unless it's done under the guidance of an orthopedic doctor or an experienced clinician, or prolonged immobilization of the particular area. Fractures should be stabilized promptly, and that can be either operative or non-operative for small non-displaced fractures. And then, of course, supportive care and very early rehabilitation, mobilization is going to be important for making sure that we have full recovery from a fracture. And all of these things will help prevent, hopefully, the development of fat embolism syndrome. Next slide. And those are my references. Great, thanks.
Oh, excellent. Okay. Thank you so much, Sarah. So I'm now going to talk about strategies for fall prevention. I'm Megan Imerino, and I'm a physical therapist who's worked in Duchenne muscular dystrophy for like 8.5, 9 years. So next slide, thank you. So why is this important? We heard a little bit from Sarah, and we'll hear a little bit from the others later, but fall prevention or strategies for fall prevention are important because kids with Duchenne have just naturally low bone mineral density. With the combination of that and chronic corticosteroid use, they are at an increased risk for fractures. Also, kids fall. So that just happens, but kids with Duchenne fall more. While we're never able to prevent all of the falls, we can't put everybody in a little bubble like we'd like to. What we can do is employ personalized strategies to help keep boys on their feet and off the ground. Before we get into this, I just want to put it in context a little bit. So your child or someone you were working with has Duchenne, but that does not have to define them. So our goal, or my goal with these strategies, is to kind of foster independence and confidence in an individual who's living with Duchenne, who can learn then self-care strategies, identify areas that they can make changes, and to minimize their own risk, maximize function, and then optimize their ability to kind of participate in the world around them. So I will say that the goals and strategies that we use will differ depending on the functional stage the individual is in. And so therefore, this is how I've decided to kind of present my ideas to you today, is based on functional level. Next slide, please. Thank you. So the early ambulatory/ambulatory phase, just FYI, I'm not talking about toddlers. I'm talking about individuals who are, let's say, five plus years of age. So the goal in this stage, this is kind of the stage where the children are most likely to be the most active. So the goal is going to be fall prevention focused on avoiding falls due to overuse and or muscle fatigue. The first consideration is with this theme, and it'll be kind of a continuing theme, is energy conservation. Kids who go to school spend like so much of their time in a school setting, so energy conservation in the school is super important. And remembering that school is for education and social skills and accessing their curriculum. So we want kids really to be able to focus their energy on that and not getting from point A to point B. So examples of energy conservation and adaptations within the school could be things like modifying expectations for gym class. So this would be allowing the child to self-regulate their activity and decide which activities are safe and appropriate for him to do. Using a wheelchair as needed for extended trips, or if they are going on they have trips planned within the school, then using the wheelchair for if that's going to be a lot or expected a lot of walking. And remembering that school modifications are individualized to the child, so it's really important. We recommend getting a physical therapy, at least an evaluation where a PT follows your child around school and identifies areas where adaptations could be made. For, again, if you're going as a family on a very long vacation, using a wheelchair for those long distances or extended travel is recommended. Avoid use of walking orthoses. So in general, the purpose of walking orthoses are to modify a gait pattern to be more of a typical or normal gait. The reason why we don't want to do this is because in boys with Duchenne is because the gait compensations that they have are because of weak muscles. So when certain muscles become weak, they modify their gait pattern in order to keep them upright. If we then try to implement and normalize their gait pattern, they're going to be then relying on those weaker muscles, which is going to increase the likelihood of falls. In some cases, they are helpful in the early years. I've seen it for like SMOs or something like that, but really we want to avoid the use of walking orthoses. Other strategies are to recognize signs of muscle fatigue and overuse. So this would include muscle cramping, those drop falls. So if a child is just running and then all of a sudden drops like kind of a sack of potatoes, that is an indication of muscle overuse or muscle fatigue, and we want to avoid or modify that activity. If a child comes home from, let's say, school or some other activity or regular activity and is so exhausted that they go to bed immediately, or they're still fatigued the next day, this is kind of a sign that that activity may be too taxing on the child and needs to be modified, or an alternative activity can be identified. I think a lot of young kids are really good at self-limiting their activity levels, but some are not. Some just like to go, go, go until they fall. If this is the case, I want to recommend kind of supporting these children, and teaching them strategies for identifying activities that are too they're too fatiguing for them. And so what this looks like sometimes is having just a very basic Likert level scale of 0 to 5, and asking the child before an activity, how tired do you think you're going to be after this activity? Where they can identify a number, and then after the activity, you can ask them again, giving them that same visual scale. How fatigued are you? Or how tired are you? How much do your muscles hurt? Something like that. This is an activity that I've recommended to some school-based physical therapists, because generally in school-based physical therapy, they're really looking at quantifiable goals. So this can be a nice goal to put within their therapy plan, so that they're able to identify how fatiguing an activity can be before and then following that activity. And then I have a little PSA on the bottom, which may not be fall related, and I'm a huge advocate for letting kids be kids, letting them engage. I mean, engagement with friends and social participation play like such a huge role in cognitive and social development and overall development. However, please, I beg of you, avoid trampoline parks at all costs. Trampoline parks are like dens of chaos and broken bones. Kids love them. Physical therapists hate them. I recommend every child avoid a trampoline park. But I've had to have these very specific conversations with families in my clinic. Okay, next slide, please. Thank you. So getting into the transitional or later ambulatory phase. So this is the time where walking is getting more difficult. Fatigue-related falls are more likely. And if a fall were to occur, the individual may have extreme difficulty or inability to get up on their own. So during this phase, we really want to focus on avoiding falls due to instability during standing and walking, and removing or kind of avoiding any environmental factors that may contribute to these falls. So first thing, back to energy conservation. It's during kind of this stage of functioning that we really start recommending utilizing a wheelchair or power mobility device regularly in school and when out in the community. So if you're going shopping, going to Walmart, the mall, anywhere that requires a bit of walking and is a crowded environment. It's in these busy environments, it's impossible to predict kind of when someone's going to bump into you, rush by you, cut you off, anything like that. So it's not necessarily always about like, I don't think that you are going to be able to get from point A to point B. It's like, we know you can get from point A to point B. However, we don't know what this guy over here is doing or this person over here is doing. So because like in this phase that standing and walking are more unstable, it becomes more difficult to kind of react to these unpredictable forces, which is going to result in a higher likelihood of falls. So using like a power mobility device simply eliminates this concern, and it kind of allows the individual to participate without that fear of falling and kind of without that threat of a fall. Other school adaptations that we recommend within this phase, again, using a wheelchair to travel between classes if it's a larger school. But we also recommend allowing children to leave class early or late. So modifying their schedule a little bit to avoid those busy hallways. If there are stairs or an elevator in the school, allowing the use of that elevator instead of requesting that the child spend all of their effort and energy going up and down stairs. In the home, I think the best strategy is to kind of remove any obstacles that might result in a trip or a fall. So this could mean in like removing throw rugs that are in the middle of the room as kind of that, like even that little change in flooring or height of the floor could cause a trip if someone's not paying attention. Other things, removing aesthetically pleasing furniture that may not be functionally placed, or decorations that can either catch a foot, a toe, or snag clothing when walking by. Again, we're really trying to focus on keeping somebody upright, and if they're getting forces that they're not expecting, such as snagging a piece of clothing on something, that could absolutely result in a very quick fall. Okay, next, please. And so for finally in the non-ambulatory and late non-ambulatory phase, falls can happen now too. The goal here is really going to be avoid transfer related falls and also avoid falls within your power chair. To avoid falls out of the power chair, the biggest thing is wearing your seatbelt and kind of getting into that habit and starting it early and having that progress through the day. Even if you're just going on a flat surface, you never know if something's going to malfunction. You never, I think just always wearing your seatbelt is important. Also, if you have a standing feature on your power chair, making sure that those straps that are keeping you in and strapped in are well functioning. The Velcro or whatever is using to keep them there is not frayed, and that those straps are in good working order. Using a Hoyer or lift system if you have one. So always recommend using a manual or a electronic Hoyer or lift system. However, and if you have one and you're able to use it, while you're able to use it, really ensuring that those sling straps are in good condition, again, that they're not frayed or split, and ensuring that the straps, whomever is putting them on to the device, is really making sure that they're looped in correctly. So that looks like the crisscross in the front so that the bottom doesn't slip out right when you lift up, and that they are on, those correct attachment points. However, it's not reasonable to assume that everybody has a Hoyer or a lift and everybody has one in every room of their home or everywhere they go. So I recognizing that, physical lifting is absolutely something that is a strategy that families use frequently. From the caregiver side, really using good biomechanics while you're lifting is super important. So saving your own back. So, using these techniques that we use of bringing the whomever you're lifting as close to your body as you can, widening your base of support, lifting from your legs, avoid bending over and twisting and moving like that. If any tweak happens and your muscles spaz and you throw out your back, then that's going to relate in kind of that transfer or lifting fall for that patient or that individual adult with Duchenne. So I think also lifting and transferring without the use of a Hoyer is very personalized and dependent on the patient, like whether they have, or the individual, whether or not they have a spinal fusion, a full fusion, or no fusion. So everything kind of looks a little bit different. So I do recommend working with your clinic physical therapist as much as you can to identify a good pattern that you can use for doing manual lifts. Then my PSA for this that is fracture related, but maybe not necessarily fall related, is that when we are doing passive range of motion or stretching, we recommend a nice, gentle passive range of motion over an aggressive stretch. And what this looks like is moving the body or moving the limbs to an end position where you're starting to feel some of that firm resistance. Once we get to that firm resistance, we say stop. If you're trying to push farther and you're trying to really kind of crank on the arm or the leg, this can actually result in a fracture as well. So we really want to focus on just keeping mobility in the joints. A lot of times these contractures can be so severe that you're not going to be able to actually stretch the tissue. We really just want to focus on keeping mobility in the joints and just moving through the active range or the passive range. Next, please. So in summary, falls happen. We still want to try to limit the likelihood of falls. All of the fall recommendations are certainly personalized to every individual, where they are in their trajectory and also kind of what their environment looks like. So working with your clinical team or your school team to identify personalized recommendations is important. We want to make sure we're using energy conservation in our ambulatory and transitional patients to avoid fatigue-related falls. And definitely avoid trampoline parks. And if you're manually lifting anybody, to talk to a physical therapist about using good body mechanics to save your own body in the case that something were to happen or an injury were to occur. That's it.
That's some awesome information there. Hi, everybody. I'm Tyler Cunningham. I am the cardiologist for our muscular dystrophy clinic here at Arkansas Children's Hospital. And I'm also an ICU doctor in our cardiac unit and in our pediatric ICU. And I'll talk about the kind of the signs and symptoms of Fat Embolism Syndrome. Next slide. So kind of the early warning signs, Fat Embolism Syndrome is rare and can be mistaken for a lot of other problems. The signs are really subtle and can occur 12 to 72 hours after a fall. And again, they're very vague. Your child could become unusually sleepy. There are minor changes in mood, faster breathing, increased heart rate, or fever. And with viral season fast approaching, that's all these signs too. But you guys know your children best, and you guys know when something is off, and you are the best equipped to find these minor changes. And if you guys are concerned, please contact a provider. Next slide. So kind of the red flags where we need to seek immediate medical attention. The first one I'm going to talk about is respiratory. Any kind of significant difficulty breathing after a fall, like meaning breathing fast. They're saying, hey, I can't catch my breath, but they're using their whole body to breathe. That's a major red flag. And then the neurologic signs, if they become confused or disoriented, they don't know who they are, they don't know who you are, they don't know where they are, what city they're in, or what year it is. They have any seizures, or if they've lost consciousness, again, we're seeking immediate care. Next slide. Then there's this characteristic rash that kind of looks like a road rash. And this is when the emboli kind of go into those skin capillaries, and the capillaries actually burst and lead to this rash. We call this a petechial rash, which means that it does not blanch. So when you press on it, it stays red. And this is kind of pinpoint spots, can happen anywhere in the body, including the whites of the eyes. But this is kind of the one of the pathognomonic signs of it. Next slide. So timely evaluation is critical because there's risks to a lot of major organs in the body. The first one I want to talk about is risk to the lungs. If emboli reach the lungs, this can lead to inflammation, which can lead to respiratory distress, which means increased work of breathing where they need a little bit of oxygen. It can lead to what we call respiratory failure, which means that we have to really support their breathing, usually with non-invasive support, which is either like a CPAP or a BiPAP machine, up to intubating them and providing mechanical ventilation. The major thing we want to watch out for is something called acute respiratory distress syndrome. So when these emboli kind of go to the lungs and lead to significant inflammation, which causes the vessels in the lungs to get really big and then get really leaky, and it leaks out all this fluid out into the lungs. And so here's on the right side of the screen, you're going to see a picture of a chest X-ray with what we call ARDS, acute respiratory distress syndrome. And when it's on an X-ray, if you see black, that means there's air there. You don't see any black on this screen. So all that kind of white patchiness, that's all fluid, other than the center thing, which is the heart. And so the majority of these kids, when they develop this, they need mechanical ventilation for a long time. Next slide. There's risk to the circulation. Again, these emboli can cause the vessels in the body to dilate up. That can lead to lower blood pressure. And the emboli can go to the heart, leading to heart dysfunction. And as we all know, that cardiac symptoms are very common as these children get older, making a already dysfunctional heart even worse. Next slide. And then there's risk to the brain. These emboli can travel to the brain, and then this can lead to brain swelling and seizures. If your child does go to a hospital and they have findings of any neurologic findings, they're going to get a head CT immediately. A head CT does not rule out fat embolus. This is a head CT on the right of a patient who came in with a fat embolism syndrome, with cerebral fat embolism syndrome, and the head CT was initially normal. I'm always a little cautious of talking about head CTs with a neurologist on the line, but here you can see that these ventricles, those little slits in the center, they look fairly normal in size. As the brain gets swollen, they get really, really small. Next slide. So how do you diagnose fat embolism syndrome? It's a clinical diagnosis, which means there's not just one finding that tells you, hey, this is fat embolism syndrome. The classic teaching that was described by back in 1970 uses this criteria. For this, you have to have 2 major criteria or 1 major and 4 minor criteria. The major criteria are going to be those red flags that we talked about. Is there respiratory distress? Is there characteristic rash? And do you have any neurologic symptoms? So 2 of those makes the diagnosis of fat embolism syndrome in the setting of a fracture. Then there's all these minor criteria. And that include tachycardia, which is a fast heart rate, development of a fever, jaundice, which is buildup of a substance called bilirubin in your body, which makes you turn yellow. There's kidney injury, which we look for in your BUN and creatinine, which are markers of kidney injury. These emboli can go to the back of the eye, which can lead to retinal injury. You can get an acute anemia, which is a acute drop in your red blood cell count. You can get acute thrombocytopenia, which is a drop in your platelets. You can get elevation in your inflammatory markers. The one that we usually look for in this syndrome is your erythrocyte sedimentation rate, or otherwise known as your ESR. And then you can also develop this fat macroglobulinemia, which is basically fat droplets in your blood. Next slide. So what to expect if you go to the hospital with concern for fat embolism syndrome? Really, supportive care is the mainstay of treatment. Unlike in a big blood clot that we can usually break up, there's no definitive treatment for fat embolism syndrome. We don't break these up. We don't go into a lab and try to suck them out. So, but luckily, early supportive care has been linked to better outcomes. So what are we going to do? We're going to support your ABCs, which is kind of what we talk about in emergency care. We're going to make sure the airway is patent. If your child has any difficulty breathing, we're going to support their breathing. Right, it's really important to let the ER team or the ICU doctors know if your child has baseline pulmonary dysfunction, meaning do they use CPAP or BiPAP at night or all the time? What kind of respiratory clearance do they use at baseline? And then circulation. It's really important to let them know if your child has baseline cardiac dysfunction. Because if your child does come in with low blood pressure, the first thing that an emergency doctor is going to want to do is hit them with a lot of fluid. And if your child already has heart dysfunction, that fluid can easily build up into the lungs because your heart's not pumping as well. And so they'd probably be a little bit more judicious with fluids if they know they have baseline heart dysfunction. So once you come into the emergency department, they're going to get IV access. We're going to do blood work that includes a blood gas to make sure that they're breathing effectively and ventilating effectively. They're going to get all those kind of secondary markers of fat embolism syndrome, which includes a CBC, inflammatory markers, electrolyte panel, including renal function. We're going to get a chest X-ray to look at how the lungs are looking. Then if there's any kind of neurologic signs at all, they're going to get a head CT. Again, know that head CT does not rule out fat embolism syndrome, though really the better test for that would be a brain MRI, but a lot of centers aren't equipped to do that in an emergent setting, and especially we're not going to do a brain MRI if they're unstable. Next slide. So what can you do if you bring your child in? Remember, you guys are the expert on your child. Let the medical team know of your concerns. A lot of providers are unaware of issues associated with Duchenne muscular dystrophy, and fat embolism is rare, especially in the pediatric realm. Make the team aware of your care team if you're at your home hospital. Any pulmonary or cardiology issues, please let them know about the pulmonary support that your child is on at baseline and their baseline cardiac function. And ask questions. I work in an ICU the majority of my time, and I tell every parent when they come in, hey, write down some questions, what you're thinking about during the day, and I'm going to come down here as many times as possible and answer them for you. And I found that that's a really helpful way to organize your thoughts, especially in the chaos of an emergency department. Next slide. So takeaways. Be on the lookout 12 to 72 hours after a fall. The early warning signs can be subtle. Again, faster breathing and being more tired. These are really, really subtle findings. And again, seek medical attention immediately for any difficulty breathing, confusion, or the characteristic rash after a fall. And please advocate and tell a medical provider about your concerns for fat embolism syndrome. Thank you. And those are my citations.
Thank you, Dr. Cunningham. That was a great summary. I'm Deepa Garbani. I'm one of the pulmonary and sleep physicians at Cincinnati Children's Hospital. And I'm going to talk more about the pulmonary course of fatty embolism syndrome. Next slide. So fatty embolism syndrome happens in almost 25% of, or I will start with 25% of Duchenne muscular dystrophy patients can have long bone fractures, usually in the femur or pelvis. Most commonly, I hear femur fractures in our patients, usually when they're being transferred. And if you look at the literature out there, 1 to 22% of the fractures have chance of developing fatty embolism. Next slide. This was a slide that Dr. Wright previously presented as well, but a quick summary. The fatty emboli come from the long bones. They enter the blood vessels and then can go into different organs from the heart and then into the lungs and can then travel into other organs, including the brain, as well as other organs. Next slide. Once there are two phases as far as the respiratory system goes, as far as the fatty embolism system. The first phase is tachypnea, which is high respiratory rate. The second phase is low oxygen levels. So when they're in the hospital, the first thing to ask for is to check a blood gas. And there's three types. There's, the capillary blood gas, a venous blood gas, or an arterial blood gas. But the most important thing is to get a blood gas. Many times, the kids will be put on oxygen. Oxygen alone is not enough. Sometimes it can actually mask hypoventilation, which is high CO2 levels. Boys with Duchenne muscular dystrophy are weak and can retain CO2, so it's very important to just not put oxygen. It's important to make sure that if they need BiPAP or need to ventilate well, that they get put on BiPAP. Or need non-invasive ventilation. So just oxygen is not enough, and checking the blood gas will help you decide that. Next slide. Also, it's important to let the provider know if your child is on BiPAP at baseline. So knowing your child's baseline BiPAP settings is also important. There can be progression to respiratory failure and needing intubation. Dr. Cunningham did talk about that. Up to 44% of patients with fatty embolism syndrome can require mechanical ventilation. Next slide. Respiratory imaging in fatty embolism syndrome. So Dr. Cunningham did show some chest x-rays. Chest x-rays can be normal, but can also show diffuse bilateral infiltrates. Many of our Duchenne muscular dystrophy patients do get chest x-rays at baseline. Being on steroids, our patients get chest x-rays at baseline just to look at spine health. And we have those x-rays at baseline. So knowing what your child's x-ray looks at baseline is helpful. As muscle weakness progresses, the x-rays will show low lung volumes. And so to know what that looks like at baseline is helpful. So when they come into the emergency room and have an x-ray, it's helpful to know what a baseline x-ray looks like. And then when you have the x-ray in the setting of this emergency, it's good to have that baseline versus the emergency chest x-ray. A CT, chest CT may also be done with the fatty embolism, which may also look normal. That doesn't mean that there's nothing going on. Next slide. Now, once they are put on BiPAP or if they do get intubated, weaning from ventilator support can also become something that needs a lot of discussion. Part of the discussion is how is their neurological status. So if the emboli have gone to the brain, that impacts how their breathing is going. So your brain controls your breathing. So how your neurological status is and how the emboli has affected the brain will impact your breathing. And the ICU doctors will talk to you about that. But once the neurological status improves and the doctors are ready to wean the ventilation, some of the things to talk about is not coming off the ventilator to room air or to oxygen, but to come off the ventilator to BiPAP. So again, knowing the baseline BiPAP settings is important, and then coming off the tube to BiPAP continuously, and then slowly coming off the BiPAP to room air and expanding the windows off BiPAP slowly is important. So again, knowing the baseline BiPAP settings is important. And then introducing the cough assist. So knowing your child's baseline cough assist settings is also important. And sometimes involving your home pulmonologist who knows your child best, and talking to the ICU team and having a pulmonologist involved also makes a difference. Just to keep everybody involved and having discussions. Initiating cough assist as you're coming off BiPAP also makes a big difference. Next slide. If they've been on ventilator support for long periods of time, which can happen sometimes, assessing swallowing function would also be important. Muscle weakness can progress if they've been intubated for a long time, and that can impact swallowing function. They may have been fine before, but that can change. So that would be something that needs to be assessed. Again, communicating with the local team that had been taking care of your child before, during hospitalization, and sometimes with the PPMD team can be very important as a resource. Next slide. And these are all my references. Thank you very much. I'm happy to take any questions.
Great. Thank you so much, Nipa and Megan and Tyler and Sarah. That was absolutely fantastic. I always learn so much from these. I do see that we've got a couple of questions in the chat, and I've also got a couple to just get us started, if that's okay. Dr. Wright, one of the things that you mentioned very early on in your presentation was that in dystrophinopathy, we see an increase in marrow fat just at baseline. Can you help us understand the why behind that?
Yeah, there's not a great amount of literature that I was looking into and trying to figure out why that is. I think that we know that steroids impact not only the muscle, but also affect the bone. And so corticosteroids obviously can really impair that essentially bone resorption and impair that homeostasis. And so that's likely a large factor as to the why.
Okay, great. That makes perfect sense. Megan, I loved your PSA about the trampoline parks because one, it's really important, but two, it's something that we hear a lot from the community about kids that are invited to birthday parties or other, social events. And I'm curious, maybe Megan, this is for you or just for the group at large. What advice do you have for parents or caregivers whose sons come home with a birthday party invitation that's at a trampoline park and they just want to participate and be with their friends? What are some potential solutions we could offer or alternatives?
Ooh, great question. I mean, again, I think this is a discussion as a family. So I do feel if they want to go and participate with their friends, that they're going to want to go and jump on those trampolines. And so I think there's no kind of having it. You can say, absolutely go for cake, go a little bit later in the day, maybe be there for cake and presents so that we can be around the kids or be around friends. But I think no matter what, if you walk into that trampoline place, they're going to go jumping on a trampoline. I think for friends and things like that, if it's a very close friend, having that conversation with the family, hey, my son, if you want my son to be included, or we want my son to be included, this is just not a safe option for them. So kind of offering alternatives for families to use is another option. I know it's really hard to say, no, you can't go to this birthday party. But I think it's kind of a personal family decision on how you want to proceed.
I totally agree. Dr. Wright, I would imagine you've probably had similar conversations with your families as that sort of neuromuscular anchor to the care team. I don't know if you have any other thoughts to add.
No, I agree. It's so hard because I think that a lot of times, an individual living with a chronic disease, right, you have a period of time where you may not be aware of your differences. But then, of course, as you start to get older, those differences come to light. And it must be really hard for a family to have that conversation. But I agree that when we talk about safety and what's the best option, it's important to keep your child's safety at the heart of everything. And I really love Megan's suggestion on talking to families about other children and educating them on what Duchenne is and what the risk may be, and talking about alternatives like how you can do your own mini party just with the two kids, right? And have your own celebration.
I think that's so important. We also have a handful of resources on our website too. So if you find yourself in this scenario, please don't hesitate to go check out some of those resources. There's videos, there's books, there's different ways to think about talking about Duchenne with peers, whether it be friends, classmates, teammates, etc. So we encourage you to lean on those resources. And if you are looking for a resource and it doesn't exist, please let us know and maybe we can work with you to create something. Um, Tyler, you talked a bit about how some of those early signs of FES can actually mimic viral illnesses. And that was an observation that I had not made myself before. So I wonder if you could just sort of re-emphasize what some of those early symptoms are, how they could mimic a viral illness, and then maybe what are some of those key things that we could be looking for or thinking about at home when we're trying to discern, is this a medical emergency versus is this, a home sick day where we need to just closely monitor?
Yeah. So it's really hard because those initial symptoms can mimic a cold, but I think again, if you're looking for like a stuffy nose, respiratory distress from FES is not going to show up like a stuffy nose. You're not going to have that sneezing. You will have the cough. And if anyone else has been sick around them, if you know that you have a positive viral contact. But I think in this setting, given the high morbidity or mortality around these kind of FES events, is that it's better to be safe than sorry and contact a provider if you're concerned about it.
Absolutely. I think that's great advice. But that actually brings me to my next question, which is for you as we think about, you know, we've done everything that we can to support bone health and to prevent falls, but for whatever reason, something has happened.
Mhm.
And we are concerned that perhaps we are looking at an FES type situation. What are the things that a family should do at home or bring with them to the hospital? So, sort of that critical time period from we think that we're seeing symptoms to arriving in the ER. What are some practical takeaways for families?
Yeah, I mean, we have, at our um, program, we do have an emergency care plan that we give to families. We always tell them to take that to the hospital because one, it has all the numbers to call, as well as the steroid plan when they go to the ER, as well as their bypass settings, the cough assist settings. So I would love for them to take that with them. So that's one thing I would recommend. If they can take their BiPAP with them, great. But if they didn't, that's not the end of the world. If they have their settings, I think that can be used anywhere. So that's would be my first takeaway is take that with you.
That's great. And
And
if I,
as the ICU doctor, I love that too. I love it when the parents give me the settings immediately. I can just plug them right in.
I love that. Should I put my child on his BiPAP at home and in transit if I'm worried that we're kind of headed down this pathway, or is that something where I should wait until I get to the ER?
I mean, if they're short of breath and if they feel like it helps them, it doesn't hurt.
Okay, great.
Yeah. If it gives them relief, sure.
Good, good. And Dr. Wright, what about stress dosing? Dr. Gurbani just briefly mentioned that. Is this a scenario where we should think about stress dosing?
Yes. So, and obviously Dr. Cunningham can also chime in. So we know that any significant stress to the body when you are on steroids, your adrenal glands, which are endogenous or in our body producing steroids, are not quite up to snuff or not quite functioning. So this is definitely something where you should be discussing with your endocrinology team, and kind of like Nipa was saying, Dr. Brownie was saying, having that emergency card, what are your emergency dose steroids in this situation, whether you can take them by mouth or not take them by mouth, is really helpful for any institution that you may go to, especially if you're traveling. I've had some families who are in Europe and sustained a fracture, and so it's really nice to have that care plan with you.
Absolutely. Dr. Cunningham, would you add anything to that steroid stress dosing conversation?
Just advocate that you tell the ER doctor that my son is on chronic steroids and may need to be stress dosed, and
Great.
advocate for that.
Awesome. Before we wrap, I'm going to plug a few of our different emergency care resources that we have available, but I think this is the perfect time to shamelessly plug, and I will do it time and time again, the PJ Nicholaff steroid protocol. So the PJ Nicholaff steroid protocol is a magnificent document. We just recently were able to release a new updated version guided by the Optimized DMD Consortium, which is a consortium of endocrinology experts from across the globe. And it talks through all of these specific circumstances. So what type of trauma and what is the severity and what does that translate to in terms of stress dosing? It's lengthy, it is, and it is absolutely written for the physician sort of provider, but it is available on our website. And we've got some family-friendly content around it too. So if you don't already have it like bookmarked on your iPhone or something similar, please go and do it now. I'm looking at time. I've got one more question, and we actually talked a little bit about this before we went live this afternoon. But one of the themes that we've heard come up a few times from the community is sort of these different manifestations of fatty embolism syndrome. So it can look like brain, it can look like heart, it can look like lungs. Do we ever see all three at the same time, or do we expect to see just one or another? Help me think through sort of all of these different systems and how they're related. Maybe this is a Dr. Cunningham question to start.
I think it depends on where the emboli go. We know that the fat embolism, unlike the blood clots, aren't just limited to the pulmonary side. They can slip through the capillaries and go systemic, and it really depends on where they land. And then again, it's not just one emboli. It's usually multiple little emboli that break up as they go around the circulation. And so I think you can definitely see all three of them at the same time. And I think most of the times you do, given that Those red flag syndromes are respiratory, neurologic, and then you see the characteristic rash, which is just those emboli reaching the capillaries in the skin bed.
Yeah, absolutely. So I think that really highlights just the complexity of fatty embolism syndrome and why we're talking about it. And of course, we'll have some additional resources available on our website after today's webinar. I'm going to quickly plug a few of those emergency resources that exist. So for those of you who are listening in, if you don't already have your emergency wallet or wheelchair card, please go on our website immediately and order a whole stack of them. We've got the wallet cards that are small. We've got the weatherproof wheelchair cards that are larger, and they have a lot of these warning signs and symptoms and what to do included there, as well as links to the PJ Nikolov steroid protocol and other types of emergency situation guidance so that if an emergency strikes, you know what to do. We also have our Think materials, which is a nice overview of some different things to think about when an emergency happens. I don't know about you at home, but I know when an emergency happens for me, my brain goes blank and I have no idea what to do. So that Think protocol is a really useful resource as well. We've also got things like emergency binders. We've got safe and unsafe medication list, normal baseline laboratory lists. We've got after hours and emergency phone lists for all of the certified Duchenne care centers. So if you find yourself in an emergency and you need to get a hold of on call on a Friday night at 2 a.m., those phone numbers are there. So please go check out those materials. And as always, never hesitate to reach out to PPMD if you're looking for information too. We're always happy to be a resource. So we are over. I'm going to go ahead and wrap things up with just immense gratitude to our speakers today, to Dr. Wright, Dr. Gerbani, Dr. Cunningham, Dr. Iamarino. It has been phenomenal to learn from you and have you join us today and help us get up to snuff on FES. And then thank you to everybody who listened in at home as well. We hope that you found this useful. And as always, don't hesitate to reach out to the care team at parentprojectmd.org to get a hold of myself and my teammates. We're always happy to field questions and connect you with any resources. And with that, we'll go ahead and conclude today's webinar. Thanks, everyone.